Welcome to the GLP-1 RA series from the American Heart Association, sharing insights on the heart and kidney health benefits of GLP-1 receptor agonists. This series is supported by an educational grant from Novo Nordisk. CE and ABIM MOC credits available.
Welcome to Heartbeats from Lifelong Learning and our series, GLP-1 receptor agonist, what you need to know. Today we will discuss obesity and GLP-1 receptor agonists. This is one of a series of the American Heart Association supported by Novo Nordisk. After this podcast, we hope you will be better able to examine the rising global prevalence of obesity and its association with diabetes and the burden of cardiovascular disease, to distinguish the unsatisfactory balance, risk, and limited effectiveness of many pharmacotherapy tested for the management of obesity, as well as identify the weight loss benefits, improvement in cardiovascular risk factors, and potential for cardiovascular disease event reduction with GLP-1 receptor agonist therapy in patients with obesity. I'm looking forward to our discussion today about obesity and GLP-1 receptor agonist. I am Justin Shufo, Associate Professor of Medicine at Johns Hopkins, and I'm going to allow my co-panelists to introduce themselves.
My name is Jane Roosh. I'm a professor of medicine at the University of Colorado in the Rocky Mountain Regional VA, and I am pleased to do everything we can to decrease metabolic risk and diabetes risk for cardiovascular disease.
And I'm Michael Linkoff. I'm an interventional cardiologist and clinical trialist at the Cleveland Clinic and a professor of medicine at the Case Western Reserve School of Medicine. Our disclosures are shown here. So Justin, let's start off, please, with why should we cardiovascular specialists be focusing on obesity? And what's the impact of obesity on our patients with cardiovascular disease?
Thank you, Mike. It's a really important question. I'm going to start by saying that one of the key reasons to focus on obesity is because it's a major public health and clinical problem worldwide. So, for example, the latest estimate of obesity from WHO indicate that more than 1.9 billion people around the world are overweight, and among those, more than 1.9 billion people, 650 million people have obesity. When we sort of look at the situation specifically in the US, the latest national estimate from the Center for Disease Control indicates that 42% of adults in the US are actually suffering from obesity. About 30% of the US adult population is overweight, and the figures are only going up. So if we look at the last 20 years, the prevalence of obesity has almost doubled. So, and particularly the prevalence of severe obesity. 20 years ago, the prevalence of severe obesity was about 5%, and more recently, it's 9%. And obesity is associated with a high burden of morbidity, premature mortality, and high cost of medical care. So if we look at the estimate from 2019, it's estimated that annually we spend approximately $173 billion because of obesity, and the excess in healthcare expenditure for one individual is about $1,800, to be more precise, for an individual who is obese compared to somebody who is not obese. When it comes to the consequence of obesity, as I mentioned regarding mortality, so obesity is associated with diabetes, which is a major risk factor for cardiovascular disease, and it's also associated with cardiovascular diseases themselves. Data from a large meta-analysis show that on average, when there is a 5-unit increase in body mass index, this will increase the risk of diabetes by approximately 72%. It will increase the risk of hypertension by 49%. It will increase the risk of coronary artery disease by 15%. And it will increase the risk of atrial fibrillation by 23%, and the risk of heart failure by about 41%. So in a nutshell, it's a major risk factor for cardiovascular disease. So that's what I can say about the reasons to focus on obesity for cardiovascular disease specialists.
I think it's also relevant to point out that most studies have suggested that that there's a direct effect of obesity on cardiovascular disease beyond even that, through the risk factors that have been associated with increased body mass.
And so I think that I'd like to talk a little bit about the mechanisms by which obesity has an impact on the cardiovascular system. So forever, until the last 20 years, we sort of just thought of obesity as a passive place to store extra calories. And then research demonstrated that the adipose tissue in the body has the capacity to make factors that specifically regulate appetite, but related to cardiovascular disease. When you have an overburdened adipose tissue, such as in obesity, then the fat tissue actually becomes unhealthy, and it begins to make hormones and or other inflammatory mediators that directly affect the heart and the blood vessels. Specifically, what we know is that what we call adipose cytokines, which are basically cytokines, inflammatory mediators that are directly coming from the fat tissue, they have a specific interplay with that 41% increase in heart failure that you just mentioned, Justin. So very important that factors that come from the adipose tissue directly and negatively impact cardiac health. Similarly, there are factors that are associated with atherosclerosis that come from the adipose tissue. And so it isn't just that excess burden of adipose tissue and its relationship to incident diabetes and hypertension, but it is a direct biological component of the fat tissue. And that is something that we are appreciating, but until very recently did not have that many opportunities to decrease or improve the health of the adipose tissue. So I want to come to Mike talking about adipose tissue and clinical trials where we are trying to affect obesity and why they have been fraught in the past and what is the hope for the future.
The history of pharmacotherapies for weight loss has been littered with a remarkable number of failures. A number of drugs, amphetamine derivatives, rimonabant, sibutramine, a number of different drugs have been either withdrawn from the market, never reached the market, usually because of adverse side effects related to tachycardias, hypertension, dependence potential, or other issues, for example, suicidal ideation with rimonabant. And moreover, aside from these safety issues, they've been remarkably ineffective in terms of the magnitude of weight loss. A proportion of patients reaching 5 to 10% has been marginal, and certainly beyond 10% has been very little. And even lorcaserin, for example, which probably made it the furthest along in terms of understanding the potential for cardiovascular reduction in risk, was only about 3% in the large trials. So first of all, from the standpoint of efficacy or the magnitude of weight loss, these have been remarkably ineffective. And then in terms of actually looking at whether or not weight loss per se can influence cardiovascular outcomes, again, the landscape is one of failed trials. Lifestyle modification, a look-ahead study was the most rigorous to test this, was not effective in reducing cardiovascular outcomes. Although they pre-specified or post-hoc subgroup analysis of those who had more than 10% weight loss, so considered responders, did suggest a benefit. So that raises the question of, is part of the failure of the pharmacotherapies thus far been because of the inadequate magnitude of weight loss? There have been several trials directed at cardiovascular outcomes with weight loss drugs, and they have uniformly failed. As I mentioned, lorcaserin probably made it the furthest along in terms of the rigor of a trial. It was one of the TIMI trials, the Camellia trial, and that showed, again, about a 3% weight loss and no effect on cardiovascular outcomes. That drug is actually not available now because I think it was a cancer signal, but thus far, no drug has shown a reduction in cardiovascular outcomes. Interestingly, bariatric surgery, although never subjected to a randomized trial for that purpose, for cardiovascular outcomes, has suggested in at least 2 observational analyses, one large Medicare and the SOS study, that may reduce cardiovascular outcomes. But those are, again, non-randomized. And the magnitude of weight loss with bariatric surgery is such that thus far not achieved by pharmacotherapies. So the question really becomes, is there something between the failure of existing pharmacotherapies and lifestyle and bariatric surgery, on the other hand, which may actually produce cardiovascular benefit? And that's where this class of GLP-1 receptor antagonists holds some promise, particular promise. So in patients who are obese or overweight, these drugs reduce weight substantially, more than any other pharmacotherapy. Up to 15% placebo-corrected weight loss over the period of time while patients are tested on the therapies, and also in patients who are diabetic, who have diabetes, then there is evidence that these drugs not only reduce weight and not only improve glycemic control, but actually reduce more cardiovascular outcomes. So several cardiovascular outcome studies in patients with diabetes have shown approximately 15% reductions in hard cardiovascular endpoints. So in patients with diabetes, in that setting, with type 2 diabetes, there's a clear standard of care at this point that these drugs are cardioprotective. What hasn't been, and what's yet to be shown, is whether or not in patients who have obesity or overweight but don't have the diabetes, whether or not these drugs would be associated with a cardiovascular benefit. And then and the promise for that is certainly one that we could speculate, but we would think would be related to not only the magnitude of weight loss, but the mechanisms by which GLP-1 receptor agonists work and the potential salutary beneficial effects on the cardiovascular system, reduction in inflammation, reduction in blood pressure, improvements in glucose metabolism and insulin sensitivity, etc. So from your standpoints with your specialties of interest, your thoughts in terms of mechanisms and promise of these drugs is certainly very relevant as well.
When it comes to mechanisms, I'm a person who's always going to have a theory or two. I do think that it is the burden of adiposity and the health of the adipose tissue that are both important. And in preclinical studies, there's been some promise, not only for weight loss, but for sort of improving the health, the inflammatory status, the profiles of cytokines and circulating factors that Justin has looked into a lot in the ERIC study that are associated with adiposity. And so I think that we're going to be looking, as we look at these cardiovascular outcome studies in people with overweight and obesity who do not have diabetes, we will be looking to try to understand which aspects of the health improvement and cardiovascular risk mitigation come from the weight loss itself versus the impact on glycemic control and other factors. So, Justin, any thoughts when you're thinking about mechanisms?
Maybe just to add to what you said, yes, obviously, there's going to be the effect of weight loss, but as you sort of rightly mentioned, so what are the sort of hormonal changes? And here, thinking about things like leptin and adiponectin, which will accompany the weight loss. But also think about the more sort of direct effects. We know that the GLP-1 receptor agonists are sort of ubiquitous in the body. It's not just in the brain where they have the primary effect in sort of reducing appetite and food intake, but we also have the GLP-1 receptors in multiple tissues. So maybe some of the direct effects that you sort of alluded to, I think when we talk about inflammation, it may sort of resolve because the inflammatory process is involved in atherosclerosis, and some of the inflammatory cells are directly involved in atherosclerosis. So there's a possibility that it has a direct effect in reducing atherosclerosis. Remember that when we look at the individual sort of CVD events, as opposed to maybe another class, which is the SGLT2 inhibitors, we have specific reduction of specific atherosclerotic events like reduction with stroke. We saw that in Rewind, and Rewind, I'm forgetting the other trial, but there was a specific reduction in stroke. There's a specific reduction in the incidence of coronary heart disease. There's also, to a certain extent, a little bit of reduction in heart failure events. It's true that there's an ongoing trial sort of trying to figure that out. That's one avenue. The other avenue is the sort of direct effect on the heart itself, because I think they're ventricular and atrial GLP-1 receptor agonists. And so, talking about preclinical studies, there's been indication that age will have an impact on probably lipid accumulation in the heart, which has a direct effect. And also, one thing that we may have forgotten is probably the effect on the kidney function. So I think there are ongoing studies sort of pointing towards possible benefits in terms of protecting the kidney, which will have resulting effect in sort of cardiovascular protection. So, and the lipid profile, I think we know for a fact that the GLP-1 receptor agonist will influence the sort of postprandial lipid profile. And I suppose that the effect on liver steatosis will also sort of have an impact on the overall lipid profile. So those are sort of the few things that I can add to what that's already been said.
That's really interesting. And I want to bring this back to Mike. And I never know if I'm supposed to call you Michael or Mike. So if I'm supposed to call you Michael, let me know. Either way, you mentioned the fraught nature of previous interventions to decrease obesity and that magic number of 10 to 15% weight loss. Can you tell us a little bit more about why that number might be magical?
From the standpoint of a cardiologist, and you can shed much more light from the mechanistic standpoint, but from the standpoint of the cardiologist, empirically, that's where there appears to be some of the evidence. So we have no pharmacotherapy that's accomplished that in a routine fashion, aside from GLP-1 receptor agonists or dual agonists, some of the newer ones being developed like tirzepatide. So, and those are the drugs that in the diabetic patients, in the patients with diabetes, have demonstrated the cardiovascular benefit. And there, as I said, there's the sub-study of the subsidiary analysis of the look-ahead study. So whether or not there's a specific reason why that threshold has a physiologic basis, I would certainly be interested in your thoughts on that. But I think that's part of it, but I don't think we should over-focus on magnitude of weight loss, because I think specific mechanism of drug is very important. We've seen that with the treatment of diabetes. There are many classes of agents that influence glucose metabolism, that influence insulin sensitivity, and the magnitude of their effects may vary somewhat. GLP-1 receptor agonists are fairly potent, but they're not in a class by themselves in terms of the changes in A1C that you see with therapy. And yet they're the only class that reduce ischemic events. Now, SGLT2 inhibitors clearly do have cardiovascular effects as well. Whether or not it's through the ischemic mechanism, the athero mechanism, is something that can be debated. But mechanism of action, I think, is as important, if not more important, than the magnitude of weight loss. Just as in the setting of diabetes, mechanism of action rather than glucose reduction is very important.
Yeah, I would like to sort of take it that one of the things about this magic number of 10 to 15% is that it goes hand in hand with specific kind of reversal of the pathophysiology by which diabetes and obesity are accelerating cardiovascular risk. And so that's really exciting and interesting from a perspective of it is clear and there is some moderation effect of glucose per se on improving cardiovascular risk in people with diabetes in response to a GLP-1, but it's not the whole story. And so when we come to direct effects of GLP-1 receptor agonists on the heart, the vasculature, the brain itself in terms of brain health, and the whole integrated physiology, that is the place where I think that we're looking to these newer agents that are sort of almost restoring normal physiology. And so it isn't that they're necessarily lowering glucose more. Insulin can absolutely lower glucose as much as a GLP-1 receptor agonist, simultaneously not treating the underlying pathophysiology. So I think that bringing this all back to the idea that GLP-1 receptor agonists were initially studied to be an agent that was going to lower glycemia, slowing gastric emptying, augmenting insulin secretion, decreasing glucagon secretion, and increasing satiety. And just as part of a protective or sort of safety study by the FDA, we tripped over the fact that they had cardiovascular benefits. So that was unexpected and really exciting. But when they looked back at those data to try and ask the question, do the cardiovascular improvements specifically correlate with glucose lowering or weight or decreased weight? What was seen is that, yes, those factors were part of modifying the improvement, but they did not explain everything. So I think we have to speculate that there are actions of GLP-1s on the cardiovascular system beyond the actions of glucose lowering and weight loss. So I think we're ready to see if anybody else had additional comments on this whole topic of obesity and GLP-1s as a cardioprotective agent. And Mike, it might be good for you to have your final comment about studies that are underway to more directly address this question.
Well, as the SELECT trial is a trial of semaglutide, which is a potent GLP-1 receptor agonist that in patients who have overweight or obesity but do not have diabetes. And a large-scale cardiovascular outcome trial, which we hope to be completed soon. What this trial does is it holds the possibility that we will have a new modifiable cardiovascular risk factor. Now, until now, we focused on some of the downstream effects of overweight and obesity, such as hypertension and impaired glucose metabolism, lipids effects, etc. But if this works, and this whole field of evaluation of GLP-1 receptor agonists in patients with overweight and obesity, this opens up a whole new opportunity for us as specialists who take care of patients with cardiovascular disease or trying to prevent cardiovascular disease. This is a huge prevalence in terms of the disease, the overweight and obesity, and so there's a large number of patients that we can potentially influence with what may be the first effective non-surgical therapy. So I think that it's very interesting and very exciting from the standpoint of a cardiovascular specialist that we may be able to influence outcome.
Maybe there are two other sort of populations in which the medication may hold the potential for benefits. And here I'm thinking about people with peripheral arterial disease. There's not much in the literature about those people, but given the thought that the GLP-1 receptor agonist may have a direct effect on processes, I think that's a population that probably will be interesting to look at. The other population in which obesity is sort of a major determinant of outcomes, people with already established heart failure, especially heart failure with preserved ejection fraction. And I think it will also be interesting to see if weight loss, at least weight loss and the accompanying effects and all the other effects of the GLP-1 receptor agonist will have on the functional status of people and other outcomes in people with heart failure with preserved ejection fraction. So those sort of two interesting populations. I think that overall, so we've sort of touched on a couple of aspects, which include the magnitude and the durability of weight loss effect of the GLP-1 receptor agonists, which substantially differentiate them from the previously tested pharmacotherapies. We've explored the concept that these drugs represent a very sort of good intermediate between lifestyle, which from a cardiovascular perspective, had not been shown to sort of be associated with significant reduction in cardiovascular events, and bariatric surgery, which is at the other extreme and for which we don't have clinical trial data. And we've also touched on the fact that a use in patients with cardiovascular disease, it may actually lead to a significant reduction of burden in cardiovascular disease because its effect is across a number of cardiovascular events, not just MACE, but also specific cardiovascular events. So that will be what I will say will be the final takeaway from this discussion. And I'm just going to proceed and thank you all for participating in this Heartbeats for Lifelong Learning and our series, GLP-1 receptor agonist, what you need to know, where we heard a lot of important points about obesity and GLP-1 receptor agonist. And in closing, I would like to encourage primary care providers and cardiovascular care providers to consider how they can proactively advocate for and utilize GLP-1 receptor agonists to improve cardiovascular risk factors and reduce morbidity and mortality related to obesity among high-risk patients in their practice. To get additional information and to claim credit, please visit learn.heart.org. The views and opinion in this podcast are those of the speakers and reflect the synthesis of science, and content shall not be considered as the official policy of the AHA. Thank you.